I will be covering perioperative low cardiac output state in two parts. Today, the focus will be a little bit on diagnosis of evolving low output state as well as some of the surgical aspects of low output state. On Thursday, I'll speak more on the medical management of low cardiac output state. At the very outset, I think we need to see why do we need to worry or bother about perioperative low cardiac output state. I think we are all aware that low cardiac output state leads to diminished tissue perfusion, which in turn affects the perfusion of the splanchnic circulation, vital organs as well as rest of the body, so that you have a cascade of events giving rise to multi-organ dysfunction, multi-organ failure, as well as death finally. And very often in most units, you have a scenario like this where babies get terribly unwell with perioperative low cardiac output state, and they are managed by escalating multiple inotropes in hugely increased doses. Now, let's look at what happens to cardiac index in children who undergo cardiac surgery. I will draw everyone's attention to a landmark paper published by Vanosky et al. In Circulation 1995. And this involved the measurements of cardiac index in neonates who underwent an arterial switch. And if you follow closely the cardiac index as well as the inotropic support, you can see the upper graph, which shows that there is a dip or a reduction or a nadir in cardiac output, which peaks at about 9 to 12 hours following cardiac surgery. And this is the time when the inotropic support is escalated. So a reduction in cardiac output is almost invariable following most forms of surgery, and the dip in cardiac index is greater if the babies undergo complex cardiac surgery or surgery which involves a long pump time. So now let's look at postoperative low cardiac output state and why it occurs. Now, this slide enumerates the various reasons why postoperative low output state occurs. One of the commonest causes are residual structural lesions which have been inadvertently left by the surgeon. In the previous talks, we've already spoken about the important role of cardiopulmonary bypass in initiating and sustaining a postoperative low output state. And the reason that CPB does this is by the intense inflammatory response that is evoked, by the degree of myocardial ischemia which entails, and varying levels of inadequate myocardial protection. So the better the myocardial protection, the more you can minimize this reduction in cardiac output. Last but not least, CPB is also associated with a reperfusion injury, which you heard earlier on the talk on cardiopulmonary bypass. Similarly, hypothermia, ventriculotomy. Larger the ventriculotomy, greater the degree as well as the frequency and the incidence of postoperative low output state. Now, those children who present late, and this is a particular relevance in our country, that is, if you have pre-existing left ventricular or right ventricular dysfunction or biventricular dysfunction, the incidence as well as intensity and magnitude of low cardiac output rate is further intensified in the postoperative period. Now, we all know that this is the kind of profile of patients who undergo pediatric cardiac surgery in our country. Older children with large left to right shunts, who have pulmonary hypertensive, who have some degree of left ventricular dysfunction at presentation, polycythemic and hypercyanotic tetralogy of Fallot, who have hypertrophied right ventricles, and some of them, by the degree of cyanosis, also have an element of pre-existing left ventricular dysfunction. All of us are aware of the increasing amount of late-presenting infants, that is transposition, total anomalous pulmonary venous drainage, ICAPA, who present with pre-existing systemic ventricular dysfunction. Now, in this substrate of patients, the incidence and intensity of postoperative low output state is even greater. We all know that there is an increasing tendency to resort to mechanical support in the pediatric cardiac intensive care unit, and ECMO and ventricular assist devices are used as a routine tool in the Western and industrialized world. There is rapid deployment of these modalities, and in some of the Western units where there is a very high incidence of mechanical support utilization, they've actually demonstrated that ventilation and intensive care can be reduced. And many of the better units have actually shown discharge survivals varying from 50 to 90%. Now, our country is a land of 1 billion people. It has a huge burden of congenital heart disease. So management of low cardiac output state, the strategies that we deploy in our country, they need to be inexpensive, they need to be simple, they need to be reproducible. And modalities should not be resource consuming either in terms of technology, money, or manpower. Highly expensive strategies like inhaled nitric oxide, EPLS, which are resource consuming with huge amounts of highly skilled manpower requirements, are really not viable therapeutic options. Now, many of these children whom I showed earlier are those who present late in their natural history. So technically, they are the candidates for mechanical support. And these are the ones from families who are least able to afford or sustain a mechanical support program. Now, the rest of this talk will really focus on a lot of our experience in low cardiac output state, which involves postoperative repair of congenital heart disease across the various age spectrums, that is starting from neonates to adults. An example is a 55-year-old who underwent definitive repair for tetralogy of Fallot. Now, we are going to look at the surgical perspective of the management of perioperative low output state. And we'll show you what is potentially feasible and achievable. I think we're all familiar with the basic Aristotle force. In this graph, you can see where we were at the inception of the pediatric program in 1995, where we had roughly a 94% survival. The red dot indicates our unit, the black dots indicate various units scattered across Europe. And what you can see is that the Aristotle force was about 6.5, which meant that we did relatively simple cases with in-hospital survival of only about 94%, which means that 6% roughly died. And that was an era where even simple ventricular septal defects died. And where we moved to about 10 years ago was an increasing Aristotle force, but with better outcomes. And the survival moved up to about 97%. And over the last 10 years, we've been able to sustain this. And today, our outcomes for the last 5 to 7 years has been more than 98%, and with mortalities, in-hospital mortalities of 1.5 to 2% during this period. And what we found was, with increasing complexity, increasing late presentation, so-called extraordinary outcomes can be achieved. I draw your attention to this review on low cardiac output stage by David Wessel, who was at Boston Children's at that time. And what this paper stated in the introduction was that progressive low cardiac output stage will occur in the postoperative patients, but appropriate anticipation and intervention can do much to avert both the morbidity as well as the need for mechanical support. So the key words are an anticipatory, highly preemptive approach and appropriate and timely intervention. And with this modality, in some of the Western units, they actually reduced the mechanical support requirement to less than 2%. So our approach was based on a lot of published data, which was highly proactive, anticipatory, but harnessing really simple and easily affordable modalities with a view to try and averting mechanical support. And what are these measures? They start actually not post-operatively, but they start during and prior to surgery. And the aim and the goal of our methods were to try and minimize the incidence of low output, recognizing that some amount of low output state is invariable following cardiac surgery. And if low output did occur, our focus was to try and identify it as early as possible. And this was by a series of methods: intraoperative measures, meticulous low cardiac output state protocol, which really focused on a very early diagnosis, aggressive therapy, very early use of milrinone, and if we had established low cardiac output state, to use an aggressive multimodal therapy, which focused on mechanical ventilation, appropriate and correct use of positive end expiratory pressure, hormonal therapy, metabolic control, management of pulmonary hypertension, as well as arrhythmia control. Now let's start with surgical modality. I think today most units resort to a transatrial repair of infant tetralogy. In the early years, low cardiac output following tetralogy of Fallot repair was huge. But with increasing recourse to a transatrial repair where you avoid and minimize ventriculotomies, the incidence and intensity of post-operative low output state following repair for tetralogy diminished. Then there are a number of other surgical strategies which we implemented several years ago, and I think most of you are aware of these. And this is to leave or create a decompressive patent foramen ovale in certain select instances. In very young infants with tetralogy of Fallot, tetralogy of Fallot with very intensely hypertrophied right ventricle, and this is to decompress the right ventricle to minimize right heart failure and secondary low output states, hugely hypertensive ventricular septal defect, hypertensive truncus arteriosus, and in some cases of the Fontan operation. The other surgical modality is to electively defer sternal closure, and it is important to have a low threshold for this. And in situations where in the operating room there is ventricular dysfunction of the systemic ventricle, where there is significant myocardial edema, where the heart appears all swollen, and persistently elevated left atrial pressures on attempted sternal closure, an example of which is late presenting total anomalous pulmonary venous connections, which we increasingly see. In all these cases, it's a very good idea to electively defer sternal closure, which means that you leave the sternum open in this fashion. It's a good idea to do this and to avoid an emergency hasty sternotomy where asepsis is possibly not adequately and appropriately maintained to avoid mediastinitis and secondary sepsis. The other very important modality, and which is particularly relevant to our country with increasing late presentation of tetralogy of Fallot, is to try and leave a dynamic right ventricular outflow gradient so that there isn't any excessive amount of right ventricular outflow muscular resection to avoid and minimize postoperative right heart failure. And this is best done by doing intraoperative echoes, either in the form of a TE or an epicardial echo, both to look at the adequacy of repair and to assess whether the residual right ventricular outflow tract gradient is dynamic or fixed. Fixed residual outflow gradients need to be addressed and repaired. But if it is dynamic, which means that in diastole the muscles relax, in that case it is very important not to excise the excess muscle from the right ventricular outflow tract. Then it's important to focus on minimizing CPB-related injury, granted that CPB induces a lot of postoperative low output states. So to ensure better postoperative hemodynamics as well as to diminish low cardiac output days, it's important to try and do surgery as quickly as possible with a view to having shorter and shorter bypass times and cross-clamp times. There is some data available on prophylactic intraoperative corticosteroid therapy, and most of us will use intraoperative steroids, especially in small infants. Our unit practice is to use them in all infants under 10 kilos and under 1 year of age. All of us are aware that ultrafiltration, whether it's conventional, modified, or combined, is useful in removing the inflammatory mediators which are generated during CPD and which induce this low cardiac output rate. Ultrafiltration is also very helpful in reducing the extracellular water so that postoperatively it is easier to wean and separate them from mechanical ventilation. There is increasing interest in the last 5 to 7 years, even in the United States, on the resurgence of phenoxybenzamine, and it's a very good drug to use intraoperatively, and it largely acts as an alpha blockade and induces intense afterload reduction. Now we are going to look at a series of cases and see how we address them. Now I draw your attention to this paper which was published from Great Ormond Street in 2004 in the journal Heart, and that looked at cardiac ECMO for biventricular heart after pediatric open heart surgery. And what Chaturvedi and Master Laval showed was that 50% of this occurred due to failure to wean from cardiopulmonary bypass. So does this happen? Yes, it does happen once in a way. And what do? We usually look very, very aggressively by an intraoperative echo for residual defects. If there are residual defects, they are fixed, and then the surgeon attempts again to separate the infant from PPD. If there are no residual defects and the problem is that of late presentation, situations are residual ventricular dysfunction or situations of surging left atrial pressures, they often use a partial cardiopulmonary bypass for varying periods of time to try and rest the heart or offload the heart and then come off pump. Now, this is an example. We had a 1.5-year-old child who had undergone surgery for a partial AVSA. At that time, she'd undergone a mitral valve repair. She represented with severe mitral regurgitation. The surgeons tried to fix the mitral valve by repairing it. An intraoperative echo showed an extremely unsatisfactory repair. So the valve was replaced. They could not wean the child from CPD. Now, what do you think we did? Can anybody answer that? What we did was we supported the child for 60 minutes on CPD and then successfully weaned off CPD by using milrinone, a low-dose epinephrine for systolic dysfunction, and noradrenaline to sustain the blood pressure. The sternal closure was referred to successfully discharged, and she's currently 3 years of age. Now, in the intensive care unit, how do you diagnose low output state early? There are multiple parameters which we have to look at, and these are broadly hemodynamic parameters, echocardiograms, clinical and biochemical. Hemodynamic, we are all aware of. If you have a central venous line, you need to look at central venous pressure. Some units cite a right atrial pressure line, then you need to monitor serial right atrial pressure. Some units cite a pulmonary arterial line, then you can measure the ongoing continuous direct measures of pulmonary artery pressure and left atrial pressure. Sudden surges, sustained surges need to be aggressively investigated. They are all warning signs of evolving low output. We should not have higher than anticipated baseline or surges of right atrial or left atrial or central venous pressure. As you saw, echocardiograms are useful both in the operating room and in the intensive care unit. They are useful to look for residual lesions, for ventricular filling, for myocardial contractility, for collection, for any other structural issues, and also indirect measures of cardiac output. Let's now look at the clinical parameters and biochemical parameters that we focus on. This is a highly informative equation, and what this means is MAP is mean arterial pressure, which is your perfusion pressure. SVR is systemic vascular resistance. CO is cardiac output, and CVP is central venous pressure. And this is a very highly informative equation. It warns you that a normal blood pressure means nothing. It does not guarantee adequate cardiac output or adequate peripheral perfusion. So what are the features that one can look for clinically? If you have unexplained agitation, if there is prolonged or deferred delayed capillary refill and the skin color is blanched, mottled, the peripheries are cool, if you have core hypothermia, diminished toe temperature, unexplained tachycardia, narrow pulse pressures, mucus pressures are dry, or a reduced urine output. A lot of these features help you in suspecting early evolving low output state. On the other hand, there are some who are stressed out, who have very high blood sugars, and they have an oncotic diuresis, which means you have a brisk diuresis. This does not exclude a low output state because you can get secondary hyperglycemia if a child is very sick. Now let's look at toe temperature. Toe temperature, if it is consistently less than 32 degrees, it's a bit of a worry, and in old days has been shown to correlate with outcome and survival. The kind of toe temperature which is very reassuring is a toe temperature of about 34 degrees. The other important clinical features of perfusion have to be looked for. Babies maintain their blood pressure by the process of intense vasoconstriction, as you saw that in that equation. So your blood pressures may be normal or may be actually elevated. So when you have unexplained tachycardia and unexplained agitation or intense vasoconstriction, this combination indicates suboptimal peripheral perfusion, and these are warning signs that your cardiac output is possibly suboptimal. What are the biochemical features? Obvious features like metabolic acidosis or reduction in the bicarbonate levels are late features. We need to focus on the subtler signs. You have an elevated anion gap, it's a worry. And some of the earlier features are mixed venous oxygen tensions, mixed venous oxygen saturations, and lactate levels. If you have palliative surgery, and this is all being deducted and worked out from the NOVO data, where you have mixed venous saturations less than 30% or an AVO2 difference greater than 30%, like in a bidirectional Glenn or a shunt or a Fontan, if these criteria are fulfilled, it means it is time for you to escalate hemodynamic support. Now, there is a lot of published data on lactate levels, on AVO2 difference and low output state. Lactate levels way back in 1997 were shown to be a good predictor of adverse hemodynamic events and near misses in infants and children undergoing cardiac surgery. They were shown to be a useful tool to adjust hemodynamic support. But in early evolving low output, many situations are found where the lactate levels are actually normal. So an abnormal or a rising lactate level predicts evolving low output. On the other hand, a completely normal low output state, a normal lactate level does not ensure that the cardiac output is normal. So there is again published evidence which shows that when you use a combination, that is serial mixed venous oxygen saturation or serial AVO2 difference in combination with lactate, they are more useful in predicting evolving low output state. What we do is, if one or the other is abnormal, or if both are borderline normal, but if you have peripheral features of poor perfusion, then we escalate hemodynamic support. So the cornerstone of successful management of postoperative low output pain is an anticipatory, proactive approach with meticulous attention to detail. Now the rest of my presentation is going to focus on some surgical modalities of intervention to improve the low cardiac output state. Now this is a baby who underwent a Fallot modified shunt. 20-day-old neonate, tetralogy, severe pulmonary stenosis, had stable hemodynamics. Late 0 post-op day, suddenly desaturates, develops borderline hypotension with mean arterial pressure only in the high 30s. Now what do you think we did? Can anyone type it in? Well, echo to see a shunt is a good idea, but we actually didn't even do that because the child was deteriorating very rapidly. We got the echo machine, there was a resident on. So what was done, because the baby started deteriorating very rapidly, a rapid sternotomy was performed in the intensive care unit. You're right, the shunt was not optimally open, the shunt was milked. The baby was being extubated 48 hours later, neurologically intact and discharged successfully. Now let's look at the next patient. 3-month-old Alkafa, severe left ventricular dysfunction, underwent translocation of the left coronary artery mitral valve repair. Epicardial echo showed a perfect repair. The ventricular function was good. So even if it was imperfect, the decision was made to separate the infant on normal support, dobutamine, nitroglycerin, and milrinone. The hemodynamics are stable, excellent. So the baby was shifted to the intensive care unit. 0 and first post-operative day were very stable. Second post-operative day, rapid deterioration. What happened? Left atrial pressure, there were surges, 10, 20, then more sustained elevations of left atrial pressure, increased central venous pressure, severe peripheral vasoconstriction, and subsequently borderline blood pressures with increasing metabolic acidosis. That we should have prevented this. This is established low output state. Now what do you think we did? We were already on full support, dobutamine, nitroglycerin, milrinone, and by this time epinephrine had also been added. What do you think we should do? Can someone type it in? Good idea. And repeat swift echo was done. There was no collection. What they did was an emergency sternotomy. And later on, when we discussed this child, we felt that even though the EF was 40%, perhaps it would have been a good idea. Since the cardiac output actually deteriorates over the 0 and first post-op day to selectively leave the sternum open. So all we did was open up the sternum. There was no collection, there was no tamponade. The baby gradually improved. Remember, he was a very sick child. He was extubated 7 days later and successfully went home. For pediatric cardiac care, there's no getting away from the fact that it's a highly multidisciplinary approach. And even if we do not pull on with each other, we have to learn to live with diverse thinking, and it's important to resolve conflict with effective dialogue. So it's very important to recognize that none of us is as smart as all of us put together, and it's a good idea to harness shared knowledge and shared expertise. So it's important to have a practice wherever you have an unexpected postoperative pause to aggressively exclude residual structural defects, which means that even if you do an intraoperative echo, serious, careful and thorough echocardiographic examination, especially if the post-op pause is unexpected by a senior cardiologist, is of paramount importance, and the subsequent cases will highlight all that has happened. 3.5-year-old child, VSC, severe pulmonary stenosis, underwent a Dacron patch closure, infundibular resection, pulmonary valvotomy, PTA ligation. Epicardial echo, excellent repair. Late 0 postoperative day, extubation. After extubation, suddenly the left atrial pressure shoots up, 20-21. Pressures begin to drift down and the baby gradually becomes acidotic and finally settles at a base excess of 11.6, and all this occurs over a matter of a few hours. And as the cardiac output state deteriorates, we kept increasing inotropes. What do you think we should do next, and what do you think we did? Can you type that in? Serial echoes showed, initial echoes were normal. Serial echoes showed a significant residual VSC, so they went back to theatre. The VSC was closed. The child was re-extubated 8 hours later and successfully discharged. This is another child, 5-year-old, complete AVSC, mitral regurgitation, Dacron patch closure, pericardial patch closure of the ASC, left mitral valve repair, PDA ligation. Epicardial echo, again, a good repair with left ventricular EF of 40%. Late 0 postoperative day on attempted weaning, left atrial pressure went up to 20 mm, and subsequently the left atrial pressure kept remaining elevated, unresponsive to conventional modalities, increasing sedation as well as increasing hemodynamic support. What do you think we should do? Well, we tried afterload reduction, we optimized milrinone, did not work. So what else do you think we should do? The LA pressures would not settle and remained double digit. Very good. That's what we did. Repeat echo was done. The mitral valve repair had given way. There was severe mitral regurgitation. Surgeons went back to theatre. Mitral valve was re-repaired. The child was extubated the following day, successfully discharged. Now let's look at tetralogy of Fallot. 6-month-old, 7-kilo tetralogy of Fallot, hypertrophy dilated right ventricle, underwent VSC closure, infundibular resection, pulmonary valvotomy, decompressive VSO. Separation from CPB was achieved on minimal doses of dobutamine. Intraoperative echo showed no residual VSC, RVOT gradient of 80. And the infant was doing quite well. Early first postoperative day, the left atrial pressures began to go up. It reached double digits. The child became tachycardic. Mean arterial pressure started to drift. And on endotracheal suction, there was fresh endotracheal bleeding. The ET bleeding was fresh and persisted. Despite sedation, would not respond, and the ET bleeding persisted. What do you think we should do next? Terrific. That's exactly what happened. A repeat echo was done by a senior. Collaterals were identified. This infant had gone to theatre with just an echo and went to the catheter lab. 2 large collaterals were found. They were coiled. The infant was weaned and extubated 48 hours later. So effectively, you have to have an algorithm like this, that if you have persistent post-operative low output, we need to have an aggressive approach. You need to see if there is residual lesion. How do you look for a residual lesion? By a good detailed echo. Sometimes echoes are difficult to interpret, especially if the windows are not good. Then a senior needs to do the echo, like in this slide. And sometimes an echo does not give clear information, then one needs to go to the catheterization lab, and some intervention may be required, like coiling of collaterals, unusual vessels, balloon thrombectomies, balloon atrial septostomies, and in some instances research. Once we are reasonably confident that there is no residual lesion, then we have to see why is the child in persistent postoperative low cardiac output state. Is it myocardial dysfunction? Is it univentricular dysfunction? Is it systolic dysfunction? Is it diastolic dysfunction? Is it a bit of both? Is it just severe pulmonary hypertension? In that case, we have to wait for the heart to recover and manage the child medically. This is yet another instance where we had a 10-week-old transposition intact victim who presented with biventricular dysfunction, underwent a 2-stage arterial switch, had profuse endotracheal bleeding finally on attempted weaning. Again, initial echoes did not pick up the collaterals. Serial echoes done by seniors identified the collaterals. Collaterals were coiled, as you can see in the subsequent X-ray. The baby was easily weaned and extubated. Now, sometimes this is when your decision making can be difficult. The earlier cases were easier. This is a 2-month-old truncus arteriosus repair with a VSD closure. Epicardial echo, perfect, excellent repair. Post-operatively, there was some measure of pulmonary hypertension, but the baby did well, was improving, and was clinically well. So we did a serial echo just prior to extubation, and we found that the right ventricular pressures were suprasystemic, with a tricuspid regurgitation jet of 132 mm. This was reconfirmed a few times. The baby looked amazingly well and looked ready for extubation on CPAP, had excellent gas. Now, what should one do? And this is all that we could see in echo. Everybody in the department repeated the echo, and this is what was an echocardiographic observation. There was a lot of pressure. The baby is doing well. Lactates were fine, mixed venous was fine, peripheries were warm, there was no evidence of poor perfusion. Go ahead, extubate the baby. Well, we were reluctant. We said we cannot extubate somebody with this kind of right ventricular pressure, so then what should you do? We were already on full support. So do you want to type that in? What do you think we should do? Can someone type it in? What we did was, we felt they had to go to the catheter lab since echo did not provide an adequate answer, and what they found was that both branch pulmonary arteries had got kinked, so the baby was taken back to theatre, had conduit revision, and after that rapidly weaned and extubated. This is yet another child, 15-year-old, tricuspid atresia, single ventricle physiology, extracardiac spontan, MPL ligation, and VT shunt takedown. Initial course very smooth, extubated early first post-op day. Second post-op day, rapid onset low output stage, huge anasarca, huge pleural drainage, 3 to 4 liters per day. Multi-organ failure. The liver enzymes skyrocketed, went into renal failure. Serial echoes were done. The Fontan circuit was patent, but the pleural collections kept worsening. and we had clinical evidence of fontan failure, persistent refractory worsening, huge anasaka. What do you think we should do next? Can someone type it in, please? Anybody? Let someone try.
Dr. Parvati, I think 2 centers have typed in fontan fenestration.
Sorry?
2 have typed in fontan fenestration.
Yes, now I can read that. So that's a good idea, and that is something that they thought about. But initially, the child was so sick, the feeling was that the fontan is working well, we will not do anything. Spoke to the family and said, we may have to declare this child. But what we all insisted was, we suggested, why don't you go to the cath lab? Short of expenses, so finally we said, why don't we just go to the theater and see what happens? And what they actually found was, when they re-explored within the next few hours, they found that the conduit was inked. There was a huge clot inside because this child had come so late. He was a polycythemic child. The conduit was revised. They actually did not have to fenestrate. Rapid recovery, and was discharged within less than a week after this. Now, I draw your attention to sum up to this paper, which was actually published in JACS in 2002, and this is from Boston children. And what they did was, they looked at children on postoperative echo. 60 cardiac catheterizations were done on children who were on post-op echo. And what they found was that there were 50 out of 60 who needed chance catheter, surgical or combined intervention. And what this paper reiterates is that residual structural defects constitute a very, very important cause of perioperative low cardiac output, a cause that can be readily prevented and addressed. Now, even if we pick up a residual defect, it has to be timely. I'll do one last case, 7-month-old complex tetralogy. Dacron patch, VSD closure, infundibular resection, transannular patch. Epicardial echo, tiny residual VSD, no RVOTO, normal ventricular function. After CPD, when they were separating from CPD, the left atrial pressures continued to remain high. The lungs were very stiff, so the sternal closure was deferred. A decompressive CFO was also made. The initial post-operative course was very stormy. A severe low output state, he was hypotensive, continued to have low blood pressures, left atrial pressures remained high, double digits, and this is a tetralogy. Metabolic acidosis, there were some lingering metabolic acidosis, -4, -5, all features of poor peripheral perfusion. Multiple echoes were done which said no residual defect. Now, what do you think we should do to this situation? This is just a tetralogy. Can anyone type that in? we actually felt that no tetralogy should behave like this, so we got virtually everybody to repeat the echo, and finally what was discovered was that on late first postoperative day, a huge VSD was found in a very unusual remote corner which had been completely missed by most of the cardiologists. So they went back to theatre, the VSD was closed uneventfully, but it was already late. There was some transient improvement, the lungs got marginally better, he continued to deteriorate, and the child died. So the message from this case is that the diagnosis of residual defect also has to be very timely. So to summarize, the surgical approach to low cardiac output state in our country, we recognize that you have a lot of late presentation, there's a lot of pre-existing right ventricular and left ventricular dysfunction. So we really need a very, very highly preemptive anticipatory approach. We should not use a knee-jerk reflex and just keep escalating inotropes. We need to be like a Sherlock Holmes and keep looking and thinking to see, however good the surgeon may be and however offended the surgeons may get, we need to keep seeing, could there something have been left behind, could there be an unusual surgical mechanical issue which can be very easily corrected, like in that fontan and in that truncus. Then focus on every conceivable measure to try and minimize CPB-mediated injury, and to summarize, prophylactic intraoperative steroids in a select group, ultrafiltration, faster and more efficient surgery, shorter and shorter bypass and cross-clap times, better modalities of myocardial protection in the operating room, epicardial echoes to refine surgical repair to exclude residual defects, to refine surgical repair, particularly in tetralogies and bad RVOTOs, to see that excessive resection is not done, inadequate resection is not done, to get things absolutely right. If an epicardial echo is difficult to interpret, to get a consultant in, to get somebody senior, to be open-minded and use multiple heads to see that there are no simple defects which can be easily corrected. Then surgical strategies we should need to take and take recourse to as preventive modalities to bail out these situations: decompressive PFOs, deferred sternal closure, protective CPB in occasional cases. Then in the intensive care unit, early and timely diagnosis of evolving low output, not diagnose established low output after surgery in the intensive care unit. A very, very low threshold to investigate and to keep on investigating residual structural defects. I again reiterate that paper from Boston Children's, which are very big time on mechanical support, and how they showed that the majority of their cases had some residual issue which was addressed in the catheter lab or in the operating room or both. And if you have an unexpected post-op course like that tetralogy, where he kept having features of left-sided dysfunction, you have to continue to search for some structural issue which can be easily and simply addressed. And even in the presence of severe low output and multi-organ failure like that fontan, we should be prepared to go back to theatre. Sometimes, even if it's late, children do come out of it once the defect is repaired and fixed. Thank you very much. Now, if there are any questions, I'll be happy to answer.
Thank you very much, Dr. Parvati. I'll just I think we'll continue this class as you had mentioned on Thursday, because that will be more of the surgical part, right, of the low output state.
And that will be more medical.
Oh, that will be more medical. Okay. So then on Thursday, we'll continue the class. Till then, thank you very much.
You're welcome. And I was thinking that we would do it like this in the form of a quiz. Is that all right?
Yes, that will